Welcome everyone to the Dr. Barry J. Matterson Endowed Featured Speaker Series in Hypertension. Dr. Barry Matterson, a well-published and widely recognized hypertension researcher and the former chair of the VA Cooperative Task Force on Hypertension, has established an endowed lectureship in perpetuity to bring leading hypertension experts to medical grand rounds. The purpose of this lecture series is to expose faculty, house staff, and medical students to prominent hypertension authorities and to provide the opportunity to posit relevant questions. It is my pleasure to introduce Dr. Sandra Taylor, Professor of Medicine at the Mayo Clinic, who has over 30 years of experience in the treatment of complex hypertension and associated diseases. Dr. Taylor graduated from Mayo Medical School and trained in internal medicine at Hennepin County Medical Center and subsequently in hypertension and nephrology at Boston University. Her clinical and research interests include hypertension guidelines, resistant hypertension, as well as the evaluation and follow-up for both living kidney donors and transplant recipients. Her research has been funded by the NIH, and she has published more than 95 articles and book chapters in nephrology and hypertension, and is also involved in provider certification and guideline creation at the national level. We are honored to have Dr. Taylor present us today on the effects of intensive blood pressure lowering on kidney function and kidney health.
All right. Well, thank you for that introduction. I'm honored to be invited to give the Barry Matterson Endowed Lectureship. I had hoped to be with you last year in person when the COVID-19 pandemic hit, and then thought for sure that it would be done by now. But Zoom is the norm, and so here I am on Zoom. So there'll be plenty of time for questions. I'm going to talk about the effects of intensive blood pressure lowering on kidney function and kidney health. So I have no relationships to disclose. By the end of my talk, I hope you'll be able to meet these objectives. First, to be able to summarize the evidence available supporting treatment of hypertension in individuals with chronic kidney disease, to reduce morbidity and mortality with regard to cardiovascular disease events and slowing progression of end-stage kidney disease. I also hope you'll be able to compare the 2017 American College of Cardiology, American Heart Association blood pressure guideline recommendations for treatment of patients with chronic kidney disease to the more recent 2021 Cadigo blood pressure guideline, and we'll talk about that. And then also that you'll be able to describe the inherent challenges in lowering blood pressure in patients with chronic kidney disease, including use of diuretics to treat volume excess and the risks of increasing the serum creatinine and reducing and worsening chronic kidney disease in doing so. And then we'll talk at the end just briefly about new options for treatment of hypertension in chronic kidney disease. So first of all, chronic kidney disease is common in the general population, and I'm sure it's common in your practice as well. Hypertension is a risk factor for chronic kidney disease, and it also occurs as a consequence of chronic kidney disease. So this is from the CDC, showing the percentage of US adults age 18 or older who have chronic kidney disease. And this is using the most recent NHANES data. And you can see that CKD is primarily a disease of aging. And so the majority of individuals are 65 or older, and actually 38% of individuals 65 or older have some degree of chronic kidney disease. It's present in men and women. It's present across races, although a little bit more prevalent in Black Americans than other races. Here you can see from the United States Renal Data Systems, similar data, also from NHANES, looking at the odds ratios for developing chronic kidney disease. And again, you can see that it is most common with increasing age, a little bit lower odds currently than in past eras, and higher odds with diabetes, hypertension, cardiovascular disease, or obesity. So if we look at the evidence supporting blood pressure targets for chronic kidney disease, before SPRINT, and we'll talk a little bit about the SPRINT data, there were really only 3 randomized controlled trials that compared a lower blood pressure target below 130/80 to the standard of the time, less than 140/90. And it only included about 2,200 patients in those 3 trials. And those are the MDRD, or Modification of Diet in Renal Disease study, and ASK, the African American Study of Kidney Disease and Hypertension. And those were both United States studies. And then RAIN-2, or Ramipril Efficacy in Nephropathy 2, which was an Italian trial. And actually, all of these studies were negative. So they failed to show a benefit of a lower blood pressure target in reducing cardiovascular events or reaching certain endpoints of advancing kidney disease, doubling of serum creatinine, or reaching end-stage renal disease or death. But there was some signal. There was slower progression of chronic kidney disease in those treated to a lower blood pressure target if they also had more severe proteinuria. And that was seen in the MDRD and the ASK trial. And then there are some late follow-up series looking at these patients over time that indicated a survival benefit for those who were randomized to the lower blood pressure groups. So in MDRD and in ASK, there was a lower risk of death in those that were randomized to the stricter blood pressure target. But there was no difference in incidence of end-stage renal disease. And that brings us to SPRINT. So I'm sure all of you are familiar with SPRINT, and I understand that some worked on SPRINT. And as you know, SPRINT was a large trial, over 9,000 patients, who were randomized to one of 2 systolic blood pressure goals, less than 120 as the intensive treatment, or less than 140 as the standard treatment group. And within SPRINT, there was also a predefined subgroup of patients who had chronic kidney disease. This was stage 3 or stage 4 CKD, and they had to have less than 1 gram of proteinuria. So the top figure here is just on the CKD subgroup, looking at cardiovascular events. And while there was a trend to lower cardiovascular events, the dashed lower line here in those treated to the intensive target, it was not statistically significant in the subgroup, but it was comparable to the whole group. And then in terms of mortality, there actually was a lower mortality for chronic kidney disease patients who were randomized to the lower blood pressure target group. But what we were really interested in is what happened to progression of chronic kidney disease. And there was no difference. So that was kind of disappointing, you could say. So in terms of reaching end-stage kidney disease or a 50% decline in estimated GFR, the blue line here is the standard treatment group, and the red dotted line is the intensive treated group. And there was no difference in terms of the incidence of reaching either of these endpoints, but the rates were extremely low. So 0.6% in both groups, and a matter of 15 or 16 patients out of 2,900. So the other way you could look at these results is that they were able to achieve lower blood pressure readings without a deleterious effect. There was not a higher progression to end-stage kidney disease in those who were treated more aggressively. So maybe in that way, it was actually positive. So if we summarize the evidence that we have for patients with chronic kidney disease, we do have evidence that more intensive treatment of hypertension reduces mortality. More intensive treatment may reduce cardiovascular events, and more intensive treatment may slow progression of kidney function decline, or at least it does not appear to hasten kidney function decline. So that brings us to the 2017 American College of Cardiology, American Heart Association blood pressure guideline. And I included the full title of the guideline here for one reason primarily, and that's that I want you to note this kind of alphabet soup. There were 9 other organizations that were represented. The guideline writing committee was led by the American College of Cardiology and the American Heart Association, but it was not exclusively written by those groups. And so these other groups, which included physicians, nurse practitioners, physician assistants, and pharmacists, were also involved in the creation of the guideline and approved the guideline. And this guideline replaces the 7th Joint National Committee report. The gist of it is that the recommendation was to use blood pressure lowering medication to treat blood pressures that were 130/80 or higher for those who already had cardiovascular disease events. So for secondary prevention or for primary prevention in those who had high risk for cardiovascular disease, a 10-year risk of 10% or higher, and to use blood pressure lowering medication in everybody else at a blood pressure of 140/90 or higher. So the new things in terms of this guideline were the lower treatment threshold and lower blood pressure target, and the use of a risk estimator to guide decisions on when to start drug therapy. Within the guideline, there are sections, one of which is regarding chronic kidney disease, and the recommendation was to treat blood pressure to less than 130/80 in all patients with chronic kidney disease, whether they met the other criteria or not. And in those who have albuminuria, and I've got the exact wording, so it's a little bit wordy here, but essentially 300 milligrams of albumin excretion per day or more, the recommendation was to use an angiotensin converting enzyme inhibitor. And in those who are not tolerant of an ACE inhibitor, to use an angiotensin receptor blocker. And the reason for that order is that the data were a little bit stronger with ACE inhibitors than with ARBs. So if we look at this in an algorithm, which is included in the guideline, again, the blood pressure goal was less than 130/80. And if the patient has albuminuria, you would use an ACE inhibitor. If they were ACE inhibitor intolerant, then go to an angiotensin receptor blocker. So there's another guideline that was released within the last couple of months, and this is from Cadigo. Cadigo is Kidney Disease Improving Global Outcomes. And this is an international nonprofit organization that has been involved working with United States representatives as well as representatives from many other countries in creating different guidelines that for diseases that impact patients with chronic kidney disease. There was a previous Cadigo blood pressure guideline that was published in 2012. So this is about a 9 to 10 year update of that guideline. And there are a couple of aspects of this guideline that I think are very relevant to discuss and compare to the US guideline. So there was a strong emphasis on accurate blood pressure measurement, and they recommended standardized office blood pressure measurements rather than routine measurements. So this would be, for instance, using an automated device that measures the blood pressure 3 to 6 times at a single sitting, about 30 seconds to a minute apart, and then gives you an average of those readings. And these types of measurements better reflect ambulatory blood pressure measurements. They also recommended out-of-office blood pressure measurements, either with ambulatory blood pressure monitoring or home blood pressure monitoring, to complement these standardized office measurements. So there was a strong emphasis on accurate blood pressure measurement before making decisions. And then I want to also mention the heat map that Cadigo has published in many of the guidelines that's very relevant to our discussion. So Cadigo has classified chronic kidney disease by the level of the GFR from 1 to 5, and that's where you hear about stage 1, stage 2, especially stage 3, 4, or 5 chronic kidney disease related to the estimated GFR, and then also by the severity of albuminuria from none or very low levels to high levels of albuminuria. And the risks here, which are color-coded, are not only the risk for progression to end-stage kidney disease, but also the risk of cardiovascular mortality or mortality from any cause in individuals with chronic kidney disease. So the worse or the lower the kidney function and the more albuminuria, the higher the risk for these negative outcomes. So if we go back to the Cadigo guideline first, the recommendation is for individuals who have high blood pressure and chronic kidney disease that they actually be treated to a target systolic blood pressure of less than 120. So this guideline goes even lower than the 2017 ACC-AHA blood pressure guideline. It does say when tolerated, and again emphasizes using these standardized blood pressure measurements, which will tend to be lower than just a random office blood pressure measurement. They go on to recommend renin-angiotensin system inhibitors for those who have CKD and more severe albuminuria without diabetes. They recommend the same renin-angiotensin inhibitors for those with moderate albuminuria without diabetes. And then for those with diabetes, they recommend renin-angiotensin blockers at both of these levels. And I think the difference here is that the evidence is stronger for those with diabetes, so they can say recommend rather than suggest. They also recommend avoiding the combination of an ACE inhibitor and an angiotensin receptor blocker or a direct renin inhibitor, that the combination of two of these drug classes has been shown to cause harm. So the way I want to put all this together, there was a recent study published just again in the last month or so, looking at the whole issue of cardiovascular risk and chronic kidney disease. So we know that individuals with chronic kidney disease are at higher risk for cardiovascular events, but the CVD risk calculators do not include chronic kidney disease as part of their estimation. So this study does a nice job of looking into that. This was a prospective follow-up of 115,000 adults 40 years of age or older in China without any history of cardiovascular disease. And they calculated their ASCVD risk, their risk for cardiovascular disease, and they also classified them by their Cadigo risk category using the albumin as albumin to creatinine ratio and the estimated GFR as risk predictors. And then they followed these individuals and looked for new cardiovascular events. So they had a 3-year follow-up. So there were about 415,000 person years and just under 3,000 events that occurred during that time. And so they looked at the eGFR and the albumin to creatinine ratio, or the log of the ACR, as markers of chronic kidney disease severity and looked at their impact on the risk prediction scores. So this is that heat map that I just showed you. And what they did is they took these risks, low, intermediate, high, or very high, that come from combining the estimated GFR and the albumin excretion rate. And they put them into here as low risk, intermediate risk, high or very high risk based on the Cadigo categories, and then plotted them or compared them to the atherosclerotic risk estimation from the ASCVD score from low to very high. And what you can see here by the color coding is that if somebody has low ASCVD risk and low Cadigo risk, their risk for cardiovascular events is low. But even if they have a low ASCVD risk, as they get into a higher Cadigo risk, their risk for atherosclerotic disease events goes up. So just with the addition of chronic kidney disease. And then this is somewhat exponential, that the higher the risk for ASCVD by the ASCVD risk score and the higher the Cadigo risk, then that leads to even higher ASCVD risk in these individuals. So the Cadigo risk categories use non-traditional cardiovascular risk factors of estimated GFR and albumin excretion, and that can further stratify cardiovascular disease risk above and beyond the ASCVD risk score alone. The combination was a better predictor than ASCVD alone, and each of the two components added greater prediction strength. So this provides us some kind of numerical evidence to support that chronic kidney disease is a risk factor for cardiovascular disease. And hopefully, these will be markers that are incorporated into calculation of ASCVD risk score in the future. All right, so I want to switch gears and go into treatment a little more. So I thought I would start with a case. So this is a 58-year-old man I called Mr. B, and he's referred to you for primary hypertension, and he has stage 4 chronic kidney disease due to diabetic nephropathy. These are his current blood pressure medications. So he's taking lisinopril 40 milligrams a day, amlodipine 10 milligrams daily, hydrochlorothiazide 25 milligrams daily, spironolactone 50 milligrams daily, and metoprolol succinate 100 milligrams daily. He limits his sodium intake and he fills his prescriptions on time. He comes in for this referral, and his blood pressure measured correctly with an automated device is 136/72 with a heart rate of 64. He has a normal cardiac and lung exam. Pulses are full, no concerning bruits, but he does have 2+ edema. Here are his labs. So his electrolytes are normal, the potassium a little bit on the high side, which fits with his medications and his chronic kidney disease. His BUN is 45, his creatinine is 2.3, and he has an estimated GFR right at 30. So you know something about hypertension, and you know that hydrochlorothiazide may not be the best diuretic. So you change him to chlorthalidone, 25 milligrams daily, and bring him back 3 weeks later, and he comes back. Blood pressure is 120/68, heart rate of 64, and he feels well. And you get labs for follow-up, and his electrolytes are fine. Potassium's a little bit lower, which is probably better, actually. But his BUN is up at 58 and his creatinine is up at 2.8. So now his estimated GFR is 24. So now what do you do? So there are some challenges in lowering blood pressure in patients with chronic kidney disease. We know that resistant hypertension is common, and these patients are taking multiple agents and have a greater risk for chronic kidney disease progression if they have resistant hypertension. Mast hypertension may also be present, so he may even have higher blood pressure out of the office, and that can be seen in 30% of patients with chronic kidney disease. We know that chronic kidney disease increases blood pressure further by impairing sodium excretion. There's increased sympathetic nervous system activity, and the renin-angiotensin system can be activated. And we know that secondary hypertension is common in patients with chronic kidney disease. So it's important to think about volume management, which can be a challenge. Chronic kidney disease is typically associated with volume expansion, and diuretic therapy is a mainstay of treatment for the hypertension and fluid overload. It's important to note that restricting sodium intake can also effectively lower blood pressure, but it's challenging to do. Thiazide-type diuretics are effective typically for stages 1 through 3 chronic kidney disease when the eGFR is 30 or higher, and loop diuretics may be more effective for more advanced chronic kidney disease, stage 4 or 5, when eGFR is less than 30, although thiazide diuretics can be used effectively in these patients, and there are studies going on looking at more potent thiazide diuretics in this group. And the dosing is really empiric based on blood pressure, presence of edema, and we usually don't have independent markers of intravascular volume to go by in selecting dosage. So it's important to go back when we think about this challenge to renal autoregulation. And this is the renal autoregulation curve. The dotted line is the normal. So in somebody with normal blood pressure and no kidney disease, there's a very broad range in which the perfusion to the kidney is maintained at a stable level, regardless of the blood pressure. This is true for brain perfusion autoregulation as well as for kidney autoregulation, but above a certain level, systemic pressures will be transmitted to the kidney, and below a certain level, the kidney will note hypoperfusion. In chronic hypertension with normal function, that whole curve is shifted to the right. So these patients tolerate a higher blood pressure, and the zone where there's autoregulation to the kidney is also higher. But there is a level above which the systemic pressures will be directly transmitted, and a higher level where when the blood pressure drops below this level, the kidney will note hypoperfusion. What happens in chronic hypertension with chronic kidney disease is that there's a loss of that autoregulation. So there's really a very narrow band of blood pressure readings where the kidney will experience consistent perfusion. And what we have to consider is that the systemic pressure is directly transmitted to the kidney, both high blood pressures and low blood pressures. And so if we lower the blood pressure in somebody with chronic kidney disease, even to 120/70, that's a mean arterial pressure of 87. And already, this is about where 87 would be. We've fallen off the autoregulation curve. So the patient's kidneys would be noting hypoperfusion. And so that may explain the rise in creatinine that we see on a hemodynamic basis with this loss of autoregulation. And if we go even lower in heart failure or with chronic kidney disease, that may be even more of an issue. And we see this in SPRINT. So there are subsequent publications from the SPRINT data looking at the incidence of acute kidney injury or a bump in the serum creatinine during treatment of hypertension. And the figure on the left is to show the cumulative hazard for acute kidney injury was higher in the intensive treated group, that's the blue dotted line, than in the standard treatment group during the SPRINT trial. And also, this is the estimated GFR during the SPRINT trial in the standard treated group for the upper curve and the intensive treated group for the lower curve. And you can see that in the first 6 months where medications may have been pulled back in those in the standard treatment group to get their blood pressure to a higher level and intensified in the intensive treated group, that directly resulted in changes in the estimated GFR, which leveled off after that. There was a slow decline in both groups that was slightly more in the intensive group, but actually fairly similar between the groups. So there have also been some reports looking specifically at those individuals in the SPRINT trial who developed acute kidney injury or a reduction in their eGFR during treatment. So the first of these was on individuals who had prior chronic kidney disease and then developed an acute kidney injury or a rise in creatinine on top of that. So there were 978 individuals who had this acute kidney injury on top of chronic kidney disease. And they had urine biomarkers measured at baseline year 1 and the end of year 4. And these are a number of different biomarkers. I've just listed them here. That have to do with injury, tubule function, inflammation within the kidney. And they found that the eGFR was lower in the intensive treated patients, but none of the tubule marker levels was higher in the intensive arm patients that developed acute kidney injury compared to the standard treatment arm. And 2 of the markers were actually lower in the intensive treated arm than in the standard treated arm. So if I can show you that in a figure, here you can see the change in GFR that occurred with intensive treatment compared to standard. There was less albuminuria, which we would look at as a benefit. And then these different markers, which generally were lower in the intensive treated patients than the standard treated patients. And so it did not correlate with this lowering of eGFR or elevation of creatinine. So they found no evidence for kidney tubule damage and concluded that the change was a hemodynamic change, as we talked about, related to renal autoregulation. There was a second report looking at patients who did not have pre-existing chronic kidney disease, but developed an acute kidney injury during the treatment. This was designed a little bit differently as a case control study, where they looked at those 162 who developed new chronic kidney disease or acute kidney injury and compared them to a group who did not develop acute kidney injury, matched by these parameters. And again, they measured urine biomarkers at baseline and at the end of year 1. And they found that certain biomarkers were associated with a greater risk of developing acute kidney injury or chronic kidney disease, but they were higher in the standard treatment group than in the intensive treatment group. And those who developed incident CKD actually had decreases in some of these markers. So again, graphically, you can see in the intensive group, there was a greater reduction in albuminuria, which was not reduced in the standard treatment group. And then looking at a couple of these markers, they were higher in the standard treatment group than in the intensive treatment group. So they did not associate with incident CKD. And again, the evidence would point that these eGFR reductions are most likely hemodynamic. So incident CKD was associated with decreases rather than elevations in the markers of kidney damage, and most likely reflect benign changes in renal blood flow rather than injury. All right, so skipping back to the clinical side, this is just to remind you that it's important that blood pressure be measured properly, including when patients do home blood pressure measurements. So this is an idealized figure, but I talk to my patients about their positioning. The patient needs to sit back supported, feet on the floor, arm resting on a desk or table at heart level. And the key piece of information is that they rest for at least 5 minutes in the chair in position before measuring blood pressure. There is evidence that taking 2 readings a minute apart, sometime in the morning and sometime later in the day, can be used to titrate blood pressure medications. It's important to have an accurate device, that it be fit properly as well. And we check our devices for patients typically once a year. And in treating hypertension in patients with chronic kidney disease, there are some basic steps. So just like in the case example, the first one would be to change hydrochlorothiazide, which is still used commonly, to either indapamide or chlorothalidone. Both are longer acting thiazide type diuretics that are likely to be more effective. If their patient is being treated with a loop diuretic, and there are a number of reasons for that we can talk about, change from furosemide or bumetanide to torsemide. Torsemide is longer acting, and you may be able to dose them once a day with torsemide. Add an aldosterone antagonist as a fourth agent based on the Pathway 2 trial, which showed a clear advantage to an aldosterone antagonist over other fourth agents. It's important to monitor for hyperkalemia, especially if you add an aldosterone antagonist, but even with an ACE inhibitor or an angiotensin receptor blocker, patients with chronic kidney disease may get quite severe hyperkalemia. And even to consider the use of one of the new potassium binders in order to keep a patient on renin-angiotensin system blockade. There are survival benefits of keeping patients on an ACE inhibitor or an ARB well into stage 4 chronic kidney disease. And so if potassium is a problem, that may be a way to manage it. Consider the addition of a beta blocker based on heart rate. Other options would be direct vasodilators, alpha blockers, or central alpha agonists. And for patients with diabetes, consider the addition of an SGLT2 inhibitor. But if you do, you may need to cut back on their standard diuretic. From Cadigo, they also emphasize that renin-angiotensin system blockers should be used at the highest approved dose tolerated by the patient. So trying to push the lisinopril perhaps up to 40 milligrams rather than sticking at 10 or 20, because the trials support the higher dose. Those are the doses used that demonstrated benefit. Changes in blood pressure, creatinine, and potassium need to be monitored within 2 to 4 weeks, I would say 2 weeks, after initiating one of these drugs or increasing the dose. And that would be any renin-angiotensin system blocker, as well as diuretics or increasing doses of those agents. Hyperkalemia can often be managed, as I mentioned, by dietary changes, by potassium binders, rather than removing the renin-angiotensin system blocker or reducing the dose. Continuing the ACE inhibitor or ARB, unless the serum creatinine rises by 30% or more within the first several weeks after either starting the drug or increasing the dose, and then only considering reducing the dose for symptomatic hypotension, uncontrollable hypokalemia or hyperkalemia, or to reduce uremic symptoms as a patient's kidney failure advances. So if we go back to our case of Mr. B, here he's got his 5-drug regimen with the chlorothalidone. Blood pressure looks good. There's been this change in labs, and you're struggling with the rise in BUN and creatinine. So I would say that that would be okay. So I intentionally made this increase less than 30% so that you would say, well, I know that this is likely hemodynamic, that the benefits outweigh the risks here, and continue with the treatment. But what if the serum creatinine does rise by more than 30%? So in that situation, you would want to assess the level of hydration. Is he over-diuresed, hypotensive, orthostatic? And you might hold the diuretic or consider reducing one of the medication doses and then continuing to monitor. And it is important to consider renal artery stenosis and evaluate for renal artery stenosis, because this is one of the clues that the patient may have renal artery stenosis that has not been detected. Reassess volume status, recheck labs, and consider reinstituting diuretic therapy at a lower intensity and then maybe going up more slowly to get the blood pressure to goal. It's also helpful to reemphasize sodium restriction. So the more you can get the patient to limit their dietary sodium, the less diuretic you may need to treat them. And there are some special challenges in the setting of severe renovascular disease. We'll touch on that, and cardiorenal or hepatorenal conditions, which I think are beyond the scope of my discussion today. So in the setting of renovascular hypertension, the renin-angiotensin system blockers can block the mechanism of the hypertension, which can be beneficial, but they can also reduce perfusion pressure and therefore reduce GFR. Renin-angiotensin system blockade could precipitate acute kidney failure in somebody with severe bilateral renal artery disease or severe disease to a single functioning kidney. And so on the other hand, they can be well tolerated and effective for less severe renal artery disease. So if you do treat someone with renin-angiotensin system blockade and they have renal artery stenosis, that may be very appropriate, but it's important to periodically monitor kidney size and perfusion. If the kidney is shrinking, it may be necessary to intervene. So even though we might not dilate and stent a unilateral lesion, if the kidney is showing signs of reduced size, that might be something to reconsider. In terms of future therapies for hypertension in patients with chronic kidney disease, I want to go back to the SGLT2 inhibitors. I don't think this is standard therapy yet, and there are some cost issues involved with getting coverage for these drugs. There was recently a systematic review, and there are a number of randomized trials that have looked at blood pressure with ambulatory blood pressure monitoring. So 7 trials comparing SGLT2 inhibitors to placebo, and 2 trials comparing to hydrochlorothiazide. And they don't have long-term late outcomes, but they do have blood pressure lowering data. And so one of the potential benefit mechanisms for SGLT2 inhibitors may be the blood pressure reduction, but the cardiovascular benefits seem to be greater than what we would expect by blood pressure lowering alone. This is from that review showing the amount of reduction you can see with an SGLT2 inhibitor is around 3 to 4 millimeters mercury systolic and 2 to 3 millimeters mercury diastolic. The third bar here on the right is hydrochlorothiazide. So it's comparable to hydrochlorothiazide in terms of the reduction from a diuretic type effect. The other interesting finding is that the reductions were greater for daytime blood pressure than nighttime, which is somewhat reassuring since we don't want to overly reduce nighttime blood pressures. In terms of device-based therapies, they're not yet ready for prime time or clinical use, still under study. Renal denervation, I'm sure you've heard about. The Simplicity 3 trial was negative in terms of not demonstrating benefit in out-of-office blood pressure control with renal denervation. There are other studies ongoing looking at various subpopulations for groups that have greater response. There also are baroreceptor devices that have been implanted, baroreceptor stimulators. There were some surgical complication issues with the early devices, and even now the trials are having slow enrollment. So I'm not sure that this will come to the clinic anytime soon. So to summarize, in terms of treating hypertension in patients with chronic kidney disease, goal one is to control the blood pressure at least to less than 130/80, and even consider, based on the Cadigo guideline, less than 120 systolic. For accurate office blood pressure measurements, ideally an automated approach would be best. Consider out-of-office ambulatory blood pressure monitoring or home blood pressure measurements. It's important to screen for sleep apnea, which is common in the CKD population. Start with an ACE inhibitor if proteinuria or particularly albuminuria is present. And if the patient develops a cough or angioedema, switch to an angiotensin receptor blocker. Add a diuretic for efficacy. A diuretic may also help facilitate combination therapy by promoting potassium excretion. If the patient has persistent proteinuria on a ACE inhibitor or angiotensin receptor blocker, consider adding a mineralocorticoid receptor antagonist or an aldosterone antagonist. Keep providing repeatedly strong guidance on salt restriction, limiting alcohol, weight loss, and active lifestyle. And look for drug interactions. It's important to review every medication the patient takes, prescription and over the counter, for potential drug interactions, particularly NSAIDs, of course, in this population, which should not be used. And utilize home blood pressure measurements, and it's important to continue to follow these patients closely. Is there a long-term risk from these acute declines in kidney function? Probably not. They're thought to be common, likely hemodynamic, and most likely reversible if you were to let the blood pressure go back up or remove renin-angiotensin system blockade. The GFR is still there. Acute declines less than 30% are felt to be an acceptable trade-off for long-term benefits in terms of reducing mortality and cardiovascular disease. So that concludes my prepared talk, and I'm happy to answer questions. So thank you for your attention.
Dear Dr. Tyler, thank you so much for this excellent presentation. And also I want to acknowledge and thank once again Dr. and Mrs. Barry Matterson for their kind contribution. Barry has been a member of the faculty since its almost inception, and is truly a giant in the field of hypertension. So we're grateful that his name can be associated with this talk and to have such an excellent speaker as Dr. Tyler. Let me begin perhaps by asking the first question. In many of the communities or in many of the patients that we take care of, especially in some of our clinics, we're challenged, and our patients are challenged, that they don't always have access to the medications that, especially in some of our communities of color, that they don't have the ability to have the ambulatory blood pressure monitoring. And so let's say they show up to your clinic for the very first time, they're already in stage 3, and your follow-up is going to be somewhat iffy. How do you approach those patients differently?
Well, first of all, I don't think that patients with stage 3 have to see a nephrologist. So I think that they can be managed by a primary provider and a nurse practitioner, a PA as well. And so this information about how to treat them needs to be disseminated at all levels. So whichever clinic is better able to work with that patient, I think is the place that should be the primary provider. There is some interesting study data looking even at the barbershop model for treating patients in Black barbershops, where they were able to show excellent improvement in blood pressure control, because that's where the patients went and that's where they could get care. I would try to work on home blood pressure measurements, and that too may be a challenge. The patient may not have access to a home machine. Those have become more affordable There are programs through the American Medical Association, Target BP, that is trying to get blood pressure machines out to patients, again, to try to help improve blood pressure control. So you don't need to have an ambulatory blood pressure monitor in most of these situations in order to work on the blood pressure. I hope that answers the question. I don't know if that was what you were looking for.
But let's say they show up in the primary care doctor's office. I don't see any other hands up yet, so I'll continue this line.
Yeah.
And their GFR is around 38, let's say. What would be your drug of choice to begin with, given their blood pressure readings, let's say, are 140/80?
Yeah. So the standard of care currently, if they're at 140/80 and they have a ways to go down to get down below at least 130/80 and even down towards 120, would be a combination medication even. And so you could arguably, I'm thinking they have albuminuria, but you didn't say that. But an ACE inhibitor or an angiotensin receptor blocker, even combined, even, the problem with the combination is it won't have chlorothalidone in it. It will have hydrochlorothiazide. So you might go with chlorothalidone and an ACE inhibitor, for instance, or you could start with the combination and then go from there.
Thank you.
The goal would be once a day therapy, especially, with initial therapy. You don't want multiple daily doses.
Dr. Matterson, any comments? Or Dr. Fornoni?
Yes, I first of all, I want to thank Sandy for an absolutely superb presentation. I do have one question. You had mentioned spironolactone at a dose of 50 milligrams. And for hypertension, not necessarily associated with CKD, we've been using as little as 12.5 milligrams. I'm not aware, because I haven't looked, what the current data are on going to those lower doses.
Yeah, I don't think there's data, Barry, for like 12.5, but I think it's reasonable to start there and, then titrate up gradually. I think the difference is if someone has proteinuria, I might start a little higher, 25, and then I would go up to 50. I probably wouldn't push it too much further than that. Again, trying to get an effect, both lowering the blood pressure and trying to reduce proteinuria.
Thank you.
I do have a first question, Dr. Teller. Thanks for the wonderful presentation and review of the guidelines. With the advent of both the SGLT2 inhibitor and the non-steroidal mineralocorticoid receptor antagonist offering so much cardiovascular and renal protection, I just wonder where you see there would be a specific population benefit from one versus the other and vice versa.
So you're talking about which drugs again?
The mineralocorticoid receptor antagonist, the finerenone, the Fidelio study, number needed to treat 21 versus 19 for SGLT2 inhibitor to prevent outcomes. I'm just really wondering, once we have them both on board, which I think would be soon, where do you see the indication to be more for one or the other?
Right. So I didn't talk about finerenone because it's not really a blood pressure lowering medication, so I think that's kind of a whole different topic, a little bit of renal protection versus hypertension treatment. So the SGLT2 inhibitors have the most crossover there. So if you're treating hypertension, I would probably go that route. There are limits in terms of kidney function, though. They have to have a eGFR, I think, of over 30 at least. So, there are some limitations there. So I think the whole field of preventing progression of chronic kidney disease is going to change with some of the new agents, but it's a little early to know which is going to go first. So yeah, I'm looking forward to that.
Thank you.
Mhm.
Thank you again, Dr. Taylor, for an excellent grand rounds. Again, Barry, thank you for your generosity, and thank everyone for attending today. Don't forget to fill out your CME or MOC as indicated in the chat, and I wish everybody a safe and wonderful day. Thank you.
Thanks so much, Sandy.
Yeah, thank you. It was a pleasure.